Everybody, welcome to chapter 10. We are going to jump into the heart. This lecture is divided up into 3 series because there really is that much content to go over. Depending on your comfort with your heart anatomy and physiology, will probably determine obviously how comfortable you are with this material. There's some hemodynamics talked about in here, so take your time and get through this as much as, or at your own pace, as slow as you need or as fast as you need to talk about it. We're going to jump in then to the overview of the cardiovascular structure and function. In your osmosis videos, they do a phenomenal job of talking about these concepts to the point where I feel like maybe I'm just repeating things from osmosis that I'm not sure I'm going to be as good or as helpful with, but I'll give it a try. These are the components of the cardiac electrical and mechanical activities that we will get into. The different disorders from the electrical systems are listed here that we'll touch on, as well as the mechanical and mixed different types of disorders. And we have our congenital disorders. To start with the overview of the heart. The heart is one of the 3 primary components of the cardiovascular system. So we've covered blood, we've covered the vascular, now we need to cover the cardiac. The primary hemostatic function of the heart is to generate the pressure that drives the blood flow through the vasculature serially to the lungs and to the organs and the tissues. To achieve that goal, their function requires electrical impulses generated by pacemaker cells at regular intervals and propagated through the heart, and contractile cells that respond to this excitation by generating pressure and ejecting a volume of blood into the pulmonary and systemic circulatory beds. Big words there for what the function of the heart is meant to do. To review what we're talking about in terms of the heart structure and the vasculature kind of put together, how does the blood flow? When the blood flows into the right atrium, the blood will flow through the tricuspid valve into the right ventricle, through the right ventricle through the pulmonary valve to the lungs, where we will exchange oxygen and gas. Once the blood leaves the lung, it flows into the left atrium through the mitral valve into the left ventricle, and then out the aortic valve through the aorta on its way to perfuse the body tissues. Thus, the heart consists of 4 chambers, but it has 2 circuits, with the right side perfusing the lungs and the left side perfusing the body. These are probably really going back to some of our basic anatomy and physiology days. But that is the understanding of the blood flow through the heart, understanding where the valves are, the right atrium, right ventricle, out the pulmonary valve, in through the pulmonary system into the left atrium through the mitral valve into the left ventricle out of the aortic valve and into systemic circulation. The cardiac cycle then that we're going to talk about is the sequence of events that is repeated with each and every heartbeat. Okay, so let's talk about these concepts a little bit. The cardiac cycle is composed of diastole, which is the resting state of the heart, where the ventricles are allowed to fill with blood. And then we have systole, which is the active state of contraction and ejection of the blood into the lungs or into the aorta. This is a rhythm and a rhythmic activity that establishes our cardiac output, the product of heart rate and stroke volume. Your cardiac output in adults, males, is about 5 liters, can be from 4 to 8. The heart can support strenuous exercise by increasing our heart rate and our stroke volume, such that our cardiac output can increase 4 to 5 times the resting amount. I like that the book says your heart is actually 2 pumps in one organ, simultaneously driving the blood through the pulmonary circulation and the vascular, or the systemic circulation. All of the pumps and the chambers and everything have to work in concert through each other through the electrical system to work appropriately. As far as the organization of the heart structure itself, remember we have 2 pump systems in one organ. That makes us have 4 chambers. We have 2 atria and 2 ventricles. Each atrium is connected to the ventricle via an atrioventricular valve. The tricuspid valve is what connects the right atrium to the right ventricle, and the mitral valve, or the bicuspid valve, is what connects the left atrium to the left ventricle. The right atrium, tricuspid valve, and the right ventricle form the right side of the heart. So if we use terms like right-sided heart failure, that's the area that we are referring to. The right side of the heart is the pump that receives mixed venous deoxygenated blood from the systemic veins and pumps into the circulatory system. So that's the right-sided pump. The left atrium, the mitral valve, and the left ventricle form the left side of the heart. And this is the pump that receives the oxygenated blood from the pulmonary vein and pumps it into systemic circulation. The 2 ventricles are connected to their outflow path via semilunar one-way valves. The right ventricle is connected to the pulmonary artery via the pulmonic valve, and the left ventricle is connected to the aorta via the aortic valve. Okay. We have a membrane, which is the pericardium, surrounding the heart, and this is a protection mechanism. So the pericardium protects the heart and the major vessels surrounded by this sac. It forms this compartment that we call the pericardial sac. The pericardial sac has 2 distinct layers. We have the outer layer, which is this tough, fibrous pericardium, and then we have the inner serous pericardium. The serous pericardium itself has 2 further layers, which is the parietal layer, and that is connected to the fibrous pericardium. And then we have the visceral layer, known as the epipericardium, which is directly adjacent to the cardiac muscle and forms the outer layer of our heart wall. Between the 2 layers of the serous pericardium is the pericardial space, and this is normally a very small area that contains a very small amount of serous fluid that allows us lubrication, essentially, for smooth, frictionless movement of our ventricles with each heart contraction. If you have pathological thickening of the pericardium or accumulation of the extra fluid in the pericardial space, you can have cardiac tamponade. When you have thickening of the pericardium, we call that constrictive pericarditis. And when you have the accumulation of extra fluid, we call that a pericardial effusion. Both of those can restrict the function of the heart and begin to press down on the ventricle, causing a tamponade situation. That restricts the movement of the ventricles, and we have a severe acute problem. Structure of the heart wall is what your book goes into next, and this talks about the heart wall having 3 layers. Let's go back to that to look at this. Okay, we have the epicardium, the myocardium, and the endocardium. So the epicardium is the visceral layer of the serous pericardium. The myocardium is the middle and most prominent layer, and this is where we are made up of the cardiac muscle tissue. And then the endocardium is the layer that lines the cardiac chambers, and it's continuous with the vascular endothelium to make up the chamber or the ventricle of the heart. So although the myocardium is the dominant layer of the cardiac wall, its thickness can vary greatly depending on the cardiac chamber. The atrial walls are typically thin because the atria are not designed to generate high pressure, but the ventricles have to be a stronger muscle to pump and create more pressure. So those are thicker. The left ventricle is the thickest, with a thick muscular wall that can generate really high pressures, normally around 120 millimeters of mercury, or systolic pressure, to drive the flow in the systemic circulation. But the right ventricle can be thinner because they only have to generate up to about 25 millimeters of mercury to force the blood flow into the less resistant pulmonary circuit. Then we get into the myocardial cell structure. Unlike the skeletal muscle, which consists of multinucleated long muscle fibers, the cardiac muscles are relatively short, cylindrical, and mononucleated cells. They have striated appearance due to the abundant sarcomeres of the aligned actin and myosin filaments, and they contain many mitochondria, as well as an extensive sarcoplasmic reticulum. The cardiac cells are linked together by desmosomes, which are clustered proteins and patches that glue together adjacent cells for mechanical coupling, and the gap junctions, which are pores made up of connexin protein subunits. With that all being said, the pores are non-selective channels that permit rapid movement of charges between the cells during action potential propagation along the thickness of the atrial and ventricular muscle walls. So this figure here is showing us the myocardial cell structure and the intracellular connections. The myocardial cells are relatively short and cylindrical, as you can see here. They are connected by specialized portions of the plasma membrane called the intercalated discs, which we can see here. The cytoplasm has abundant myofilaments consisting of the actin and myosin. And these are arranged in sarcomeres. Cardiac cell junctions at the intercalated discs include the desmosomes that are mechanical links between the cells, and the gap junctions that are electrical links between the cells, as we can see here. So when you're talking about the intercalated disc, we want to know that there's the desmosomes to provide the mechanical tethering, but then we also have the gap junctions to provide the electrical coupling between the cells, so the signals can be passed along the different cells. This here is what we'd start to talk about the myocardial cell membrane potentials. I want to point out a paragraph in your book that I think is worth mentioning, the myocardial oxygen supply and demand, and to highlight in this paragraph here the part that it talks about that we receive a lot of blood flow into the myocardium, even at rest, and more than any other organ except the kidneys. The heart has the highest oxygen consumption of any organ. So the heart itself, to run, requires an extreme amount of oxygen. So it consumes a lot of oxygen. This high consumption is due to the constant workload of our rhythmic muscle contractions, and the fact that the heart uses aerobic metabolism exclusively. So we need oxygen for our metabolism of our heart. The main fuel for the heart is energy-rich free fatty acids. The high myocardial demand for oxygen presents a point, though, of vulnerability because the high rates of coronary artery blood flow and turbulent blood flow dynamics at the coronary arteries predisposes the coronary arteries to atherosclerosis, which is what we talked about in Chapter 9. And these narrow arteries will reduce the blood supply to the hungry, oxygen-dependent heart myocardial muscle, and that leads to ischemia. I think it's important to hear it said that way because it's really indicative of why we can have such devastation from small arteries being included within the heart, because we need so much oxygen consumption in our heart to keep going that MIs are very devastating, is the word I would use. I did want to point that out. I like the way that that is said in here. Okay, next we get into the cardiac part of the heart. So we're going to start by talking the myocardial cell ion channels and transports. Getting into a lot of the technical parts of things here. Okay, so the electrical and mechanical events of the cardiac rhythm activation and pump function, right? So we have to have our electrical system to make the pump system work, and it has to work in a coordinated way and manner. So the electrical system is a crucial component because without it, our pump is not going to stay synchronous with the two sides, and we would have a totally disorganized blood flow, which is why when people have electrophysiological disorders or the contractility of the heart isn't so good, we get in a pickle because we really do actually need the heart electric system to work well and work in concert, or we're kind of up a creek, so to speak. And it's actually, if you think about it, we utilize the cardiac system, the monitoring of the cardiac system, as our way to monitor invertedly, so to speak, inversely, the function of the mechanics of the heart, because they're so tightly coupled. So when we have mechanical problems of the heart or alterations, then that tends to alter our circuitry as well. And when we can monitor circuitry through something like an EKG, now we have a way to see that something has gone askew, maybe with the structure or the mechanics, but we find that through monitoring of the electrical system, which is pretty cool. Okay. The myocardial cells are excitable cells, which I would sure hope for. We want them to be active and receiving the impulses and conducting the electrical impulses of the heart. So they have a high rate of the active transporter sodium potassium adenosine triphosphatase activity that establishes and maintains the gradients across the plasma membrane. Okay, so this is when we start talking about the sodium, calcium, potassium pumps that work with our myocardial cells and their membrane potentials. So at rest, the membrane is most permeable to potassium. So that sets a resting membrane potential, which is a voltage difference across the membrane in which the intracellular potential is negative relative to the extracellular fluid. Okay? So if you have a voltage-gated ion channel and it's selective for either sodium, calcium, or potassium, that will change the action potential of the cardiac cells. Okay? So this is what it's showing us here, is that we have channels that involve potassium, sodium, and calcium with the gap junctions, but we also have transporters of the sodium-potassium pump, the calcium pumps, or the sodium-calcium exchange pumps. So the heart has its own impulse generation and conduction system that initiates the rhythmic beats and coordinates the function of the cardiac chambers. The conduction system structures are made of cardiac muscle cells with electrical properties that are different than those of normal contractile cardiac cells. Under normal conditions, the cardiac atria are almost completely electrically insulated from the ventricles by the fibrous cardiac skeleton that supports the cardiac valves. So the two atria and the two ventricles are in direct electrical contact with each other, but normally the only impulse conducting pathway between the atria and the ventricle itself is through the bundle of His, or the AV junction. So this is a view of the cardiac conduction system. We have an interior view of the frontal section, the frontal plane through the heart. And we can see the action potentials are generated at the regular intervals by the pacemaker cells of the SA node, so the sinoatrial node, which we know is here. Okay. The action potential propagates through the pathways to the right and to the left atria and through specialized internodal pathways to the AV node. The action potential propagation slows briefly at the AV node, but then it accelerates through the bundle of His, the bundle branches into Purkinje fibers. The Purkinje fibers propagates the impulse through the walls of the right and left ventricle. So under normal circumstances, the action potential to start the cardiac contraction should be generated in the sinoatrial node in the wall of the right atrium. And then it goes through the internodal pathway to the AV node, and then the interarterial pathway to the left atrium, while also propagating through the right atrium. The slowest impulse conduction will occur at the AV node, creating the AV nodal delay. And that is really important to understand in normal cardiac function because that AV nodal delay allows the atria to contract while the ventricles are still relaxed at the end of diastole, finishing the ventricular fill-in. So sometimes we call this the atrial kick. The impulse is then conducted to the ventricles, causing the ventricular contraction during systole. From the AV node, the pulse is then conducted through the His bundle to the septum, which separates the two ventricles. The His bundle divides into the left and right bundle branches that further branch to supply the left and right ventricles, and then both of the bundle branches reach the cardiac apex and conduct to very rapidly conducting Purkinje fibers that continue to distribute the cardiac impulse through the ventricular muscles. So understanding this concept of the cardiac conduction system is going to be very important because this is the foundation to understand EKGs and 12 leads and all of the different disorders of the cardiac system and where things have gone wrong. We have to understand this. So the heart is composed of these excitable cardiac muscle cells, and they have to undergo this electrical activity. This involves talking about the different action potentials of these cells. And when we get to these technical things, I find them still to me to be kind of confusing when we get into a lot of technical terms. So I do think the book does a good job of breaking this down. What this picture here is trying to show us is that the action potentials differ in the different cardiac regions and cells. So the cells of the sinus node and the atrial muscle and the ventricle muscle have action potentials with distinctive phases and shapes. Rapid propagation through these electrically coupled cells is facilitated by gap junctions and is capable of bidirectional movement. So what they're trying to show us here is like the ventricular mode has a fast action potential, And so really what we're seeing here, right, is that what we look at like on our tracing of our arterial line, we see this kind of line here, this potential, which is the ventricular systole. Below that, we are seeing the sinoatrial node, which is a slower action potential. And then below that, the atrial muscle, which is the fast action potential. So that is a helpful image, maybe for some of us, to see what we're talking about when we talk about action potentials. Our conduction pathways through our cardiac electrical system are meant to ensure a highly coordinated sequential activation of the chambers that leads to optimal ventricle filling and ejection. The contraction of the cardiac muscle then generates the force to increase ventricular pressure, providing the driving force for blood flow into the circulatory system. These understanding of these different action potentials come into play when we talk about the electrophysiological diseases and then some of the antiarrhythmic drugs that we get to use in pharmacology will further describe where they act within this action potential of the ventricle. What I would want us to realize from these here is that the ventricular action potential is meant to be a fast response to get that thick ventricle to work together quickly to get the ventricular squeeze. We have to have a resting and refractory period, okay? And this is where arrhythmias will come in when we don't have a good refractory period. I do want to point out the book does make sure we understand that we have cardiac cells that can be delineated into pacemaker cells and non-pacemaker cells. So the far majority of the cardiac cells are non-pacemaker cells, and these cells are specialized to do the work of contraction, but they are fast response cells. Our pacemaker cells are about 1% of the cells, and these are the ones that are specifically found in the SA and AV nodes. And these cells spontaneously generate the action potentials at a regular rate and a regular rhythm. And based on their ability to have their action potentials, they're also referred to, though, as slow response cells. Okay? Because in these nodal spaces, they potentially act slower to slow down the impulse, and that is a purposeful thing. The rate of action potential generation of these cells being slower is modulated by autonomic nerves. So if we have parasympathetic activity, we're going to decrease our heart rate. And if we have sympathetic activity, it's going to increase the heart rate. And those things happen at the SA and the AV node. We have the potential to slow it down or to kick it up. But the non-pacemaker cells, they just act very quickly. They conduct the impulse, and that's all that they're going to do. When we talk about refractory periods, this is the time in the intervals during the action potential when membrane excitability is at or near zero. Okay. We have to have a purpose of time where we're at complete rest. We have what we call the absolute refractory period, and at this point the membrane excitability is zero. So another depolarizing stimulus cannot work to create a new action potential or a new stimulus. Then we have what we call the relative refractory period, and this is when the membrane can produce an action potential, but it can only do that in response to larger than typical depolarizing stimulus. So when you're looking here at this image here, the RP, the absolute RP, is a bit longer than the relative RP. Then we have the supernormal period, and that's the end of phase 3, which is briefly more excitable than normal, and then we get back into the phase 4, which is the normal level of excitability. Box 10.1 in your book does a phenomenal job of explaining these different phases of 0, 1, 2, 3, and 4. Please read through those and see how much sense those make to you, because they're kind of a lot to think about. This one here again is showing us though that the calcium channel and how that impacts between the calcium and potassium, and how those electrolytes and those channels will affect our action potential. Going back to this with the absolute RP and the RP relative. The relative RP does occur when some of the sodium channels are recovered, their inactivation gates have opened, and during this period, if a larger than typical stimulus causes the opening of the already recovered channels, this triggers membrane depolarization and a second smaller action potential following on the first. That is likely to happen when demands on the slope of phase 3 repolarization occur. And the more rapid it is, the more likely a second action potential can be generated. So, one class of our antiarrhythmics, which is like class 3 amiodarone, actually works at this part here by blocking the potassium channel, thereby prolonging the relative refractory period and make it less likely for that ectopic beat to kick off and cause trouble where it should. Next, we talk about the idea that the slope of phase 4 depolarization in the sinoatrial node regulates heart rate. So when we're healthy in a normal physiologic state, the SA node pacemaker cells provide the impulse for our cardiac contractions. So every action potential that's generated by these cells is propagated through the AV node, and that results in ventricular contraction. So what we've just described is the normal sinus rhythm. So our heart rate, our beats per minute, which is known as chronotropy, it's determined by the frequency of action potential generation of the SA node pacemaker cells. So that's a lot of complicated terminology to say that in normal sinus rhythm, the SA node pacemaker cells work the right way and go through the AV node and give us a ventricular contraction. Once the pacemaker cell membrane depolarizes to the threshold potential, the voltage-gated calcium channels open and you get your typical action potential generated. So the SA node firing rate is primarily determined by the duration of phase 4 spontaneous depolarization. The SA node firing rate is primarily determined by the length of time it takes for the cell membrane to depolarize from the maximum diastolic potential to threshold potential. Our intrinsic SA node firing rate is typically 100 beats per minute under conditions of no autonomic input to the heart. The SA node cells are innervated by both sympathetic and parasympathetic branches of our autonomic nervous system. So both the sympathetic and the parasympathetic nervous system can work within the SA nodal cells, ultimately increasing or decreasing heart rate. This is essentially showing us the different ways that we can decrease our heart rate through our parasympathetic nervous system. This one is showing that we can do it through the, again, the heart rate slowing through the phase 3 with a more negative membrane potential due to increased potassium permeability. We're going to kind of blow through these because I don't want you guys to get caught up in the weeds too much of this. And the osmosis videos do such a good job of explaining this much better than what I would do. This slide here is helping us understand that we can have a heart rate increase as an effect of norepinephrine by stimulation of our sympathetic nervous system. These are some really lovely pictures of the gap junctions that are helping to conduct the action potential. And we're going to jump right through those as well. The idea here is that the faster the depolarization associated with the sodium channel activation is, it's going to be more efficient for the rapid conduction through the atria and the ventricle. This is a nice picture that helps us show that the action potential shape changes from a pacemaker cell, which we said was slow, to the non-pacemaker cell, which is fast. So this is just showing us that in this nodal activity here it is slower, but once it reaches the non-cardiac pacemaker, it's very fast. And this is really important to understand. When we're talking about the non-pacemaker type action potential, they just race through these contractile cells with this intercalated disc and the gap junctions. I mean, that makes sense. Within the split of a second, we can conduct an impulse all the way through these non-pacemaker type cells. So what we have to also remember, though, is that our drugs that we're going to give down the road could be influenced or can influence this system if we alter calcium, potassium, or the different resting membrane potentials, and all of those things can be altered with medications to change the electrical cycles of the heart. The example is that we know that calcium channels play multiple roles in our cardiovascular function. And the book goes into talking about this and to understanding that the calcium channels are found in vascular smooth muscle cells, so they're very important in maintaining our basal vascular tone. But in the heart, the calcium channels are found in both contractile and pacemaker cardiac cells. So the calcium concentrations in our blood and our calcium levels very much can affect our vascular tone, but also our electrical system of the heart. In your SA node, your increased L-type calcium current contributes to heart rate acceleration because it lowers the threshold potential. In the AV node cells, increased L-type calcium channels cause increased conduction speed. So with all of this being said, the manipulation of calcium can cause different action potentials within the heart. So, increased L-type calcium currents in these action potential cells cause a stronger contraction, so increased contractility. Cardiac muscle L-type calcium channels are stimulated by beta-1 adrenergic receptor activation. That results in an increased heart rate. It also results in AV nodal conduction speed and increased contractility. So if we use calcium channel blocking drugs like amlodipine, they are going to block the L-type calcium channels in the vascular smooth muscles and are going to decrease arteriolar tone, and thus vascular resistance will go down. So we use these drugs in treatment of hypertension. But if we use cardioselective calcium channel blockers like diltiazem, now we're going to block the L-type calcium channels in the cardiac muscle cells. And so now we are going to affect the rhythm of the heart. So we can use the cardioselective calcium channel blockers in arrhythmias because they will lower the heart rate and they'll lower the AV nodal conduction speed, but they also will slow cardiac or decrease cardiac contractility. So we have to be very careful about using calcium channel blockers in heart failure. This image here I actually find incredibly helpful because it is linking what is going on from the single cell in the electrical system as it's reflected then on the EKG. So when you see this here at the start of the P wave, if you go up to what we've got going on here, the start of the P wave, this influx of calcium into the SA node, right? And we're beginning part of our action potential of the SA node. And as it distributes out then to the atria to cause them to contract to come to the AV node here, now we have finished the P, and now we're getting into our PQRS. So by the time you're going to the downslope here, what is happening is that we're getting the resting potential activated with Purkinje fibers. So our QRS over to our T is reflective then of the impulse carrying through the completion of the ventricles into here. I just find this helpful to kind of see when I'm seeing a P wave, I'm seeing this action potential of the SA node working through the atria. When I see the AV node, I realize that I'm getting to the end of the PR or the P wave and the PQ interval here. I think it can be really helpful for us to see. So the rapid depolarization of the atrial non-pacemaker cells is detected first as the P wave, and this is sodium mediated. The delay, or the PR interval, reflects the conduction delay at the AV node. So this delay in here is what we see through the AV node. Then we get the QRS complex, which is also sodium mediated, which shows the depolarization of the ventricular non-pacemaker cells. And then we can see with the T wave here is finishing its action potential, and we're getting to the refractory period for repolarization of the ventricular cells is reflected by our T wave. So if I were to ask you a question of what section of the EKG represents atrial and AV nodal conduction, that would be the PR interval. If I were to ask you what section of the EKG represents ventricular repolarization, you would say the T wave. If we were to ask you what does the P wave represent on the EKG, you would say atrial depolarization. When we talk about the EKG, before we go into arrhythmias, it's important to remember your EKG is a snapshot in time that is capturing a brief section of a series of electrical events of the cardiac conduction system. And you see it reflected in the slopes of the wiggles on the paper, right? And so our EKG can be very effective to show us, yes, the conduction system of the heart, but also can lead to potential revealing to us some of the mechanical problems of the heart. So what do I mean by that? If I know that my T wave is supposed to be giving me the reflection of ventricular repolarization, or the QRS is supposed to be showing me the ventricular wall depolarization, if I have an abnormal QRS, so something's gone askew, it may be because something in the ventricular wall has become abnormal, like an infarct, right? So if I've killed off a section of cell here and I've altered the route of the pacemaker cells to be delayed or to have to go in a different direction, that is going to change my reflection of my EKG. Okay, so if I have abnormalities of this physically, I'm going to see it reflected on my EKG. Also, if I were to have abnormalities of other structures of the heart, I may see that reflected in my EKG. So even though this may be wrong in terms of size or shape, it's not because necessarily the electrical system itself has gone wrong, but how the electrical system flows through the cardiac muscle, something has happened to alter that path. And that's why we see a changed EKG. Anytime you have a generated action potential outside of the SA node, we call it ectopy. So everybody has ectopy. That's probably one of the most important things to remember. If you hooked all of us up to a 24-hour EKG monitor, we're all going to have a PVC, a random weird beat that generated outside of the SA node. It is a normal variant. When you have them too often or in frequency, that's a different story. Because our body is always going to have compensatory mechanisms, if we were to lose one of our nodes, like they died from ischemic changes, then the other nodes want to take over. So the AV node and the other subsidiary pacemakers have diastolic depolarization. They can function as pacemakers themselves. The AV node or the subsidiary pacemakers are usually suppressed because we have faster rates of the SA node coming through. Typically speaking, the SA node wants to give 60 to 100 beats per minute. The AV node wants to give 30 to 60 beats per minute, and then the subsidiary pacemaker cells of the ventricles give less than 30 a minute. So those ones are never going to have to generate themselves because there wouldn't be enough time to do that. The SA node's going to take over. The latent pacemakers can generate the heart rate if the SA node fails. So if the SA node fails to give the electrical impulse, you can have escape rhythms like a junctional rhythm, where the impulse is being started in the AV node and not the SA node. The non-pacemaker cells can develop pacemaker-type characteristics when depolarized, or ischemic, or under sympathetic stimulation. The ectopic and triggered activity can generate extra beats in addition to the sinus beats. Okay? So this is what we're talking about, the latent pacemaker function. The SA node is 60 to 100. So when the SA node is in charge, we typically are going to have a heart rate over 60 and should be less than 100, and we should have a normal sinus rhythm. If the AV node junction is the only thing driving the rhythm, now you're going to have a junctional escape rhythm. So the EKG tracing is going to look different, and it's going to have a slower heart rate. If the only thing working is the ventricular ectopy, like the bundle branches of the Purkinje network, now you're going to have an idioventricular rhythm, and we're in big trouble, right? Because our heart rate's less than 40, and we're hardly functioning in the heart at all. Bad news bears. Ectopic beats can be normal, right? We can get PACs, premature atrial contractions, and they're probably very harmless normally. They can become a problem when we have too many of them. We can also have ventricular premature contractions, and that can be done in the absence of disease, just rare ectopy beats that we get. However, we're going to have a lot more ectopy if you have hypoxia or ischemia, or increased sympathetic tone, or hyperkalemia. So if you have someone on an EKG monitoring system and you occasionally get a PVC or a PAC here and there, it's not of any concern. But when you start seeing frequent ectopy, lots of PACs, lots of PVCs, we have to begin to think that something is going wrong. We have to think of things like hypoxia, ischemia, or electrolyte abnormalities. Irritability of the heart and the pacemaker cells. You can have these extra beats set off a series of events to lead into a tachyarrhythmia, and you can also have a early depolarization during relative refractory period can generate a series of extra action potentials and send us into a refractory ventricular arrhythmia, as we can see here. One of the things we can have that's very problematic also is our conduction blocks. So normal cardiac excitation relies on the cell-to-cell communication of the action potential throughout the heart via the gap junctions. The typical conduction pattern also relies on the forward, which we call anterograde conduction, so moving forward, the conduction from the SA node to the rest of the cardiac muscles. However, the presence of gap junction allows for different conduction patterns, including a retrograde conduction, which is problematic. Conduction blocks can be complete, whereby the conduction is slowed or blocked in both directions, and that typically occurs at the AV node, where conduction is slowest in the first place, and this can lead to various degrees of AV blocking, which often is going to cause bradycardia, because you're not going to allow the sinoatrial one to come through. You're going to have bradycardia from a slower heart rate. Conduction blocks may be unidirectional, whereby the normal forward conduction blocked, but retrograde conduction is intact, but it's slower than normal. Well, that's no good either. If you have myocardial ischemia or infarction in certain areas associated with calcium accumulation, that's going to block the gap junctions. So then you can get focal conduction blocks in the regions of ischemia, and you can see those on the EKG. This is what we're seeing in like a bundle branch block or a fascicular block. If the retrograde conduction is sufficiently slowed enough, then you can get a re-entry circuit where you get that feedback and it just keeps going over and over and over and over, like Wolff-Parkinson-White. So re-entry arrhythmias are also likely to occur because the conduction pathway is longer than normal, or there's an additional conduction pathway between the atria and the ventricles. When you are dealing with re-entry circuit type arrhythmias, they typically cause very high heart rates. This is what it looks like to see a regular sinus rhythm. So we're in lead 1 here. So we have a P wave, and these are present and they map out down the way. This is a QRS complex that march down the way. The distance from the P to the QRS, the P waves, are the same size all the way through. This one is going to be your first degree block because the distance from the start of your P to the start of the QRS is too long. It is taking way too long from the SA node impulse to get through to the ventricle impulse. You have some kind of block probably in the AV node. So a first degree AV block. A second degree AV block means that the P waves are not followed by a QRS complex. So you get these moments of failure of AV conduction at all. We call it Mobitz type 1 or Mobitz type 2. Mobitz type 1 shows progressive PR lengthening before non-conducted P wave. Many of us probably learned like Wanky-Bach, and we would say Wanky-Bach, and it would be longer and longer, and then you'd get a P that's not conducted. Then we can have third degree AV block, which is big problem. That's where the sinus, atria, sinonode, and the ventricles are not talking at all. So there's no relationship between your P wave and your QRS. So your atria are up there doing their own thing, and then the QRS are down there doing their own thing. So you've lacked all association between the atria and the ventricle. This is problematic, and it's considered really life-threatening. Sometimes bradycardia can be caused by blocks, sometimes it's because of medications, and sometimes it's because of infarct or ischemia that killed off part of our pacemaker cells. Tachyarrhythmia is anything with a heart rate over 100. The three general reasons for a tachyarrhythmia are because of increased automaticity of the SA node, a triggered activity, or a re-entry tachycardia. Okay, so AV nodal reentrant tachycardia. A really fancy word with a lot of letters there. So the sinus beat is conducted along a fast pathway to the bundle of His. The slow pathway has a refractory section, and that impulse enters the AV node, but it's blocked. The fast pathway impulse stimulates distal end of the slow pathway, and you get the retrograde back up, and you all of a sudden just have both of these impulses going, and you have an extremely fast rhythm. So in A, here on the screen, we can see that this the SA node generated impulse is propagated through the AV node via the fast pathway. That excites the distal end of the slow pathway, setting up an impulse propagated in the retrograde direction. In B, we can see an extrasystole reaching the AV node while the fast pathway is in its refractory period, and it's propagated via the slow pathway. Upon reaching the distal end of the fast pathway, a retrograde impulse is generated back into the fast pathway. And then C shows us either condition that causes retrograde propagation in the fast pathway can then create tachycardia by repetitive activation of the AV node, and you get a circus rhythm. Wolff-Parkinson-White is a very specific disease that is an accessory pathway between the atria and the ventricles that can bypass the AV node completely, and you get a really big reentrant circuit. Without the extrasystole, the impulse moves intergrade between the atria and the ventricles, creating the delta wave, which is the early rise of the QRS complex. So if you ever hear about the delta wave, it should trigger Wolff-Parkinson-White. With that extra beat, then the circus rhythm creates this tachycardia. So this accessory pathway should not be there, and you just create this loop circuit that goes faster and faster and faster. Shouldn't be there. All right, next we can move on to atrial fibrillation. It is the most common chronic rhythm disturbance of all. In atrial fibrillation, you should not have discernible P waves because there is a complete lack of atrial depolarization coordination. There's no rhyme or reason to the P waves. They're buried within the rhythm. You also get irregular QRS complexes and pulse. So you're kind of all over the place. So you get an irregular rhythm. The typical ventricular rate in AFib is around 140 to 160. We can get AFib as a consequence of aging because we can have the atrial enlargement from hypertension or from heart failure or from valvular disorders. If you have a disease that increases the atrial pressure and the size of the atria, that will also promote atrial fibrillation to develop. So think of valvular disease like mitral stenosis, but also things like heart failure, hypertension, heart disease, or pulmonary disease. Additional predisposing risk factors include thyrotoxicosis and frequent alcohol consumption. Sometimes you get AFib in the elderly and you cannot find a cause. People can also get AFib, though, from too much caffeine, too much alcohol, or severe lung disease. It can also be initiated by ectopic foci at the junction of the atria with pulmonary veins. The problem about atrial fibrillation is we have pathologic consequences. So we can have three major complications. We can get decreased ventricular filling, so we get poor cardiac output. We get the tachycardia, and we can get a thromboembolic event. So if we lose our atria kick, the coordination of our atria to work in sync, to turn on the ventricles in sync, to get complete ventricular filling and a good ventricular squeeze, then we are going to be vulnerable to activity intolerance. We are not going to be able to oxygenate our bodies well, and you don't feel good, and you don't have good cardiac output. The tachycardia shortens diastole and filling, so that now compromises myocardial oxygenation and vulnerability to ischemia. So now we also don't have good cardiac oxygenation to the muscle. And then we know that you can have atrial blood stasis, which is the major risk factor for TIA or stroke, and so people are often managed with anticoagulations. Or now we have the procedure like the Watchman. Ventricular tachycardias is defined by technically 3 or more consecutive ventricular premature beats. It's divided arbitrarily into 2 categories. We have sustained VT, which is more than 30 seconds, and that typically will produce syncope or a pretty severe symptom. And if you have sustained VT, you're probably going to need cardioversion. Then you can have non-sustained VT, which is shorter self-terminating episodes. Okay. So sustained VTAC is a problem that is going to be considered life-threatening. Both forms of the ventricular tachycardia are common in heart disease, ischemia, infarction, heart failure, ventricular hypertrophy, valvular disease, or some of the congenital cardiac abnormalities. It can also be caused by reentry tachycardias or other arrhythmias. Ventricular tachycardia is life-threatening because it will convert into ventricular fibrillation, and that is very limited to no cardiac output. All right, Brugada syndrome is one of the first diseases. It's caused by an inherited autosomal dominant mutation in the fast sodium channel gene. A potential clue to the presence of this syndrome is varying forms of ST elevation in the leads V1 through V3 on your EKG. The problem is that pattern can show up chronically or just sometimes intermittently. So the ECG findings may be unmasked when you give sodium channel blocking antiarrhythmics like flecainide or procainamide. Brugada syndrome is a potentially fatal disease, and intracardiac defibrillator implantation is the most effective way to prevent an arrhythmic death. The long QT syndrome is when a genetic mutation affects the fast sodium channel or delayed potassium channel, and this causes enhancing excitability or delayed repolarization of the non-pacemaker action potentials. So that's a problem. The prolonged QT can lead to a type of life-threatening polymorphic VT called torsades de Pointes. The various gene mutations with this autosomal dominant and recessive pattern can result in the long QT syndrome. Arrhythmic events may be precipitated by a variety of factors, including exercise and abrupt sounds or being startled. Patients typically suffer palpitations, syncope, seizures, or sudden cardiac death. if you have a patient with long QT syndrome, you should never give them drugs that prolong the QT interval or reduce serum potassium or magnesium levels. And that gets us through. Oh my goodness, we made our way through the first section. Again, I don't know if my lecture here or my talking through the content is helpful for you guys or not. Please make sure you're utilizing the osmosis, because they do a fabulous job of explaining these things pretty darn well, I think. We'll see you in part 2.